Next, I'd like to please welcome Dr. Susan Farkus, a cardiology specialist with over 35 years of experience, currently practicing in Fargo, North Dakota. Originally from Hungary, she graduated from Semmelweis Medical University and now serves as the medical director of the Sanford Echo Laboratory, where she specializes in echocardiology and cardiac imaging to diagnose and treat structural heart diseases. Please welcome Dr. Farkus.
Okay, good afternoon. I will speak today about a different subject than the aortic valve disease, but just as much it's very dear to our heart, pun intended. But before I start, I got inspired by Dr. English's comments here and presentation and talking about rural healthcare. You know, we do serve a lot of rural patients, even we work in Fargo. So I never forget one story what stuck with me for I don't even know how many years, and this will be a very quick one. I was on call, and I was called into the emergency room and also later on to the operating room. A 32-year-old male was roughhousing with his brother on the back of the pickup truck, far away in the rural community. He fell down, hit his chest, and everybody thought this is a trauma, rushed into the hospital. The first thing what they found is the aortic dissection. So he ended up coming to us. We do the CT scan, and we know that we have to go to the operating room with him very quickly. And while we are doing that, the CT scan, we just look at it, and we also found he also had a clot on the right side of the heart. So we went to the operating room, we took care of him. Luckily, he survived. He did very well. A couple of years later, I was on call again, and I was called for an aortic dissection. And turned out to be, this was this gentleman's brother, the one who he was roughhousing with in the back of the pickup truck. This time, he went in with a chest pain to the same emergency room, but as they didn't find anything, they wanted to send him home. Except his mother was in the emergency room and did not let him to leave. She requested actually a CT scan, and sure thing, he also had an aortic dissection, this time without any trauma. We never thought that the first gentleman had any genetic abnormality at that time. And retrospectively, obviously, both of them had. But it's just that story what stuck with me for years in practice, but both of them luckily did quite well. So rural communities still can, diagnose, send the patient to the appropriate, treatment, and they both did quite well. It's just one of those interesting. So we are going to talk about, because this is an educational forum, and I'm not going to talk much about aortic valve disease this time, but we are going to talk about women and heart disease because I find it also very important. So why exactly we are talking about women and heart disease? Isn't that the same as in men? Do we have to treat it differently? Do we have enough evidence that how should we make a decision? What kind of research should we do? And do we have different guidelines for women than for men? And what do we need to do actually not to harm women, which I should have put up as a number one? So just a little bit of the history about this and just a couple of definitions. The sex defined by chromosomes, as most of us know. The gender is actually how an individual self-identifies themselves. And now we really need to talk about also transgender individuals who identifies as the opposite sex or non-binary. The sex-specific is unique to the one sex. The sex difference is incidence, prevalence, and etiology of the different diseases. And we cannot apply results obtained from one research using one sex history only. And the NIH initiative to balance these policies actually just started not so long ago. It wasn't always very obvious to everybody that that's what we should be doing. So this is just a little cartoon here, but I think it tells the story. If we don't know which drugs are safest and most effective for pregnant women and children, why don't they just let us into more clinical trials to protect you from the drugs which are not known, right? Unstudied or unknown drugs. So this is like a catch-22. So here is some statistics. The #1 killer in women is heart disease and not breast cancer, but everybody thinks so. The improved knowledge, but still 46% of the women unaware that actually their highest risk is heart disease and not breast cancer. Risk factors can be very different and more widespread for women. The women usually older when they get heart disease, and they have much more comorbidities, which also affects the care, what they receive. The delays presenting to the emergency room and the delays being treated is very obvious when you take care of women like I do. It's always something more important than themselves. So they have to finish the cleaning or pick up the kids rather than going to the emergency room with symptoms. The higher mortality, even after thrombolytic therapy, but it has the same benefits. So sometimes women don't receive the treatment, decide they would have the same benefit from it. And this is a very sexist comment here, but it's actually came from the famous and well-known and wonderful Nanette Wagner, who is almost 85 years old now, I think. And the medical community has viewed women's health almost with a bikini approach, looking essentially at the breast and reproductive system and almost ignoring the rest of the women as part of the women's health. And so after all these, more of the recognition came, and what do we need to do? It's very, very early on in 1948, they started the Framingham study. And that's one of the largest trials when they looked at risk factors and coronary disease and cardiac disease and followed these patients from Framingham, actually, for more than 30 years. 1955 was the first time when age and sex considered to be risk factors for coronary disease or myocardial infarction. And men had the heart attacks at age 30 and 40. And women had it actually 10 years later. So that was the recognition when they realized that women get the disease older. It's usually postmenopausal age. So the conclusion was that heart disease is men's disease, period. 1974 was an interesting trial which looked at the risk factor correction trials, or they looked at it, what happens if we start looking at the risk factors and start treating them. That's a very debated trial still today, but it's mainly included women, or not just mainly, but only, and focused on the risk factors and what happens if we treat them. Can we decrease the prevalence of myocardial infarction? And actually, and the mortality mainly, and they found that starting statin therapy is actually very beneficial. And they found that has significant decline in mortality when they started to take statin therapy. So this is another cartoon here, but again, quite tells the truth. We have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition. But medical research using women as subject just never occurred to anybody. Women received also another story, which is part of this history that we know and became now quite well known, that women received this hormone therapy, estrogen, mainly for treatment of prevention of heart disease. And that came from the Nurses' Health Study. And that was when they started to look at it, that what happens when women get the estrogen for prevention of heart disease. And it was a disaster. So what happened is that women actually had higher prevalence of heart attack, and that's noticed that maybe this hormone therapy is not really what beneficial for women. Again, go back to what my original premise was, what do we need to do not to harm women? So what medications we are not supposed to do, so they are women actually protected. The Women Health Initiatives study led by Bernardine Haley, when she got there into that position, NIH in 1991, and included 150,000 women. In 1999 was the first year when Lori Mosca, who is a wonderful researcher, and her group actually started to publish the first guidelines on prevention in women. In 2000, the Women's Health Initiative published that the hormone therapy actually harmful for women. So 1 year later, 17,000 less heart attack in women as the hormone therapy was stopped, and women received actually statins the same time. Media help, which I really went through all my professional life. I could see what media actually can do, and that's why thank you for doing what you are doing here. But any kind of media presentation, when we target something, we know that it's actually very beneficial. So the media help was significant since 2002, when American Heart Association led a campaign, and a lot of people know about it, Go Red for Women. When everybody was wearing red dresses, you have a little pin with the red dress, and also started to talk about heart disease in women each year more and more, and that way we actually could measure that how much women became more knowledgeable about heart disease and the risk of heart disease. The 2019, which was just a couple of years ago, the preventive guidelines came out, but some of the women-specific factors were not included even in that guideline. 2020 was the time when the updated guidelines, after the women researchers stepped in and they started to publish these, that the recommendation came out for primary prevention for women. The secondary prevention guideline, what does it mean, primary and secondary? The primary prevention, when we give medications or we give advice and lifestyle changes and everything else to women or men who did not have any kind of disease documented yet, but they have risk factors, and we encourage them to look at the risk factors. The secondary guidelines are for people who already had something, like you had a dissection, or you had a heart attack, or you had something already what needs to be further followed up and treated with medications. So teaching and defining risk factors and specific recommendations for women is indeed needed, and we know that it's very important. So when look at women and heart disease, these are one of the posters what's available in a lot of places. We look at that, and we really would like women to know about the heart disease, know the risk factors, look at it, and look at the female-specific concerns. This is one of the first posters which were actually available for that. Look at the health problems during pregnancy. For years, we did not think about pregnancy has something to do with later on how much risk you have having a heart attack. We know now that women who have problems during pregnancy, such as high blood pressure, high cholesterol, having preeclampsia, which is complications of the pregnancies with leg swelling, with shortness of breath, with high blood pressure. We know that these women later on higher risk for having coronary artery disease and heart attack, the women who don't have problems with their pregnancies. And a lot of ovarian cysts, we sort of said this is just a reproductive disease. We know that those women also higher risk for having heart attack later. The breast cancer, we are going to talk about it, but that's also somewhat in the list of the risks, and also the kind of birth control women use before pregnancy, and then the follow-up on that also important. So mitral regurgitation, that's one of the valve disease we are going to talk about just very briefly. And I just picked up a couple things to talk about what's more common in women than in men. You know, this is one of those things, the mitral regurgitation, the leaking of the mitral valve, which sometimes comes with if someone has problem with the aortic valve also. They can have rheumatic heart disease, or what we know that, interestingly, mitral valve prolapse is more common in women. Men are more likely to have surgery than women for mitral valve prolapse, but women also has higher mortality. This is a very old data. I can tell you now that the minimally invasive surgery is what we do, and other treatment what we do for this mitral valve disease is actually, I don't think there is a huge difference between the outcome of men or women. Women also less likely to receive mitral valve repair. It's probably also not as true in our country or right now where we are. But the elderly women has a higher mortality. You know, we know that women live longer. They have more comorbidities also. And also the late presentation is one of the problems. You know, they don't go to the doctor. It does not get discovered. Part of it also that might not be heard, the murmur as well, especially if women are overweight. So the aortic valve disease also, again, we talk a little bit about it. The non-rheumatic, that means they did not have rheumatic fever as a child, but they have like inherited or age-related aortic valve stenosis, is more common in women than in later age. Again, women live longer, and then for some reason, we think that it's more common. And more non-surgical valve replacement happened in women also, and this is part of it, again, the survival issues too. One of the explanations is that women live longer, also has a smaller size of the aorta, smaller size of the valve. So when it starts calcification, meaning that deposits of the calcium in there, the valve area becomes so small that it's not able to push through the valve, the blood anymore. So these women present actually quite symptomatic, and putting a valve into this area through the groin, this is a transcutaneous aortic valve replacement, when we don't have to open up the chest. And these procedures are very beneficial for women, shorter the recovery time, and even with a lot of comorbidities, they do usually very well with it. And then the aortic dissection, more common in men actually than in women, and twice as common. But when it occurs in women, they are older age and usually less likely go through surgeries or have more chance of dying during or before even the surgery. Now, we talked about the pregnancy a little bit, and again, for years we didn't know this, but it's actually the pregnancy-related mortality, 16 per 100,000 live births in 2006 to 2010. This is really increased due to cardiovascular and infectious causes. Hypertension, that's the main reason, either chronic or pregnancy-related. Recently, in the last couple of years, actually the guidelines changed because our colleagues, the OBGYN, the gynecologist colleagues, were not so quick on or not so keen on treating high blood pressure in pregnant women. The worry was, of course, the blood flow to the fetus and so forth. But now we know that much better blood pressure control is actually beneficial. We don't do as tight blood pressure control as we would do someone else, but we still, the numbers changed a little bit. The stroke is an increasing trend, unfortunately, with pregnant women. And the preeclampsia, as we talked about, is considered a risk factor for coronary disease later life. Peripartum cardiomyopathy, again, this is very specific for women, obviously. And what is it? the peripartum, meaning that this definition that the woman has heart failure symptoms and heart failure during the pregnancy, usually the last month of pregnancy and within 5 months postpartum. So we see some women going through pregnancy, birth, go home, they're doing fine, and then they come back with severe shortness of breath, leg swelling, heart failure symptoms, and that means that the heart is not pumping the way how it should. They usually don't have previous history of any heart disease, and the ejection fraction, that's the pumping of the heart, is markedly decreased in these women. It's in the US, in the majority of them, is 1 month postpartum. The etiology remains unclear. The emerging risk factors are genetics, maybe obesity, maybe untreated high blood pressure, but we think more and more is the main reason. And the symptoms as with any other heart failure symptoms. And because it became more of a knowledge and more media and more information about it among the GYN docs and obstetricians, and the obstetricians are starting to look for this and take it more seriously and call us in time. So these women actually treated and recover and do better. The future pregnancies remains an issue. It's related how well the ventricle actually recovers, and but could occur again, interestingly, at least 20% of the time. We have a very frank conversation with the family, with the woman, and we discuss the future pregnancies. I happen to follow a lot of women who had second or even third pregnancies after postpartum cardiomyopathy. We watch them very carefully together with our obstetrician colleagues. We do testing regularly. We do pre-testing before they decide to get pregnant. And we also discuss that the best option is obviously if the heart function is still normal, they have a normal stress test before they get pregnant, then the outcome is likely better. And some of them will have some decrease of their heart function during the second pregnancy, but most of the time we can get them through, and we follow them very closely for that. And it's 50% mortality of 6 years with persistent cardiomyopathy at 6 months. So we know that even without the pregnancy or not being postpartum cardiomyopathy, a decreased heart function is not a good thing to live with. And we know that it's a very high risk of mortality or dying from that. Now, some of these women, and more patients have ultrasound of their heart before they become pregnant, or an ultrasound during their lifetime, and then they decide to get pregnant. We know that the lesions that are leaky valves, those are usually well tolerated during pregnancy. We do have the conversation about it, what to watch for. But the narrow, the stenotic lesions are much more difficult. And these women need also very, very, very close monitoring. I usually follow patients who have like aortic stenosis, the narrowing of the valve, and we try to get them through pregnancy as much as possible, rather than saying that you cannot get pregnant, you cannot have children. Rather than that, we have a very good conversation and decide that how should we pursue it. Putting a valve in before they get pregnant is very problematic because of the anticoagulation what these women would require. They are young, so most likely they would like to have a valve which lasts longer, and those are usually the metallic valves. So putting a metallic valve for a woman who would like to get pregnant is not something what we like to do. Putting a bioprosthetic valve, which sometimes we do, then we have to have the conversation that most likely after the childbearing age, we do need to put a different valve in for the rest of her life. So these are very difficult and very problematic conversations, but it has to happen, and has to happen with the family and the woman, and also with all our knowledge and all our research, what we know about this. The congenital, these are the aortic valve disease. who were born with it. That's usually the case in these young women who want to get pregnant. The valvuloplasty is an option, and we did that too sometimes. That gives you about a couple months when they can get through the pregnancy, they can have the baby, and then we can decide what to do about the valve after that. Marfan syndrome came up here for a couple times mentioned. That's a congenital or born disease which affects not just the aorta itself, but the aortic valve as well as the mitral valve. And it's the tissue is the problem, the connective tissue, and therefore, these we like to be corrected before or during pregnancy if the size of the aorta is 45 millimeter or 50. And genetic testing has more and more role in this to decide who should be or should not be corrected. All these patients have nowadays genetic testing, also because they would like to know what's the chance of the baby having any inherited problems, and also we would like to know what the chance of having any problems during the pregnancy. Now, another topic when we're talking about women and heart, as I said, this will be like a smorgasbord here. We are going to go through a couple of diseases what's affecting women, and more women than men usually. And this is the spontaneous coronary artery dissection, or SCAD. About 20 years ago, we didn't even know about this terminology of SCAD. Some patients were said, oh, you just had a heart attack, nothing wrong with you, otherwise we have nothing in your artery, what would, we can do for you, and this is just, women's heart attack. 30% of the heart attacks occur during pregnancy. The 30% is the spontaneous coronary dissection patients, 30% during the pregnancy due to the SCAD. So unlikely that a pregnant woman would be like a heart attack due to the plaque or atherosclerosis, which is much more common in the older age. So overall, like 1 to 4% of the acute coronary syndrome, if we get recognized, it's not rare. So that's what getting more and more knowledge about it and information about it. There is some familial prevalence, but it's not so sure yet. Still working on deciding the genetic markers on it. The Mayo Clinic is a leading in this, so collecting blood from most of the patients who go there for spontaneous coronary artery dissection, and they think they're finding now the genetic markers for it. The STEMI, that means a heart attack, what comes with a very specific EKG change, elevation, what we call it, and these are about 50% of the cases. And interestingly, 23% has more than one vessel. The more complications with the stent placement, you know about stents. These are little wire mesh what we put into the coronary artery to keep it open when someone has a heart attack or have angina or chest pain. And that stent placement actually causes problems with the spontaneous coronary dissection. When we put the stent in, it can dissect the whole vessel, even back to the aorta. So we don't recommend actually stenting. These flap, what occurs with the dissection, this is very similar to the aortic dissection, but occurs inside of the coronary artery. That flap, what elevates or lifts up, that flap actually has the tendency to be healing by itself. So if the pain goes away, we give the right medications, that dissection actually can be healed. So a lot of my patients did not get a stent. Sometimes they do if it's too big or we are not able to control the pain. They sometimes do end up putting stents in, but that's the rare occurrence. Conservative therapy, especially because these vessels are small and tortuous where this occurs. Again, the SCAD is the recurrence in 10 years is 21%. I have one lady who had 4 episodes of documented spontaneous coronary dissection. It's occurred in different vessels, and she survived all of them. She still doesn't have a single stent. And interestingly, her heart function actually remained normal. Cardiac rehab and stress management is very important. The statins, which is the mainstay of our therapy nowadays because we know it's beneficial for everybody, is not necessarily needed for these patients, only if they otherwise would have very high cholesterol. If they would have just the normal cholesterol level for a 35-year-old woman or a 30-year-old woman, we not necessarily start statins on them. The nitrates are important. This dilates the artery, and any other medication that helps to dilate the artery, like calcium channel blockers, are beneficial. And everybody gets a scan the first time it occurs, top to bottom, a CT scan. We are looking for other findings. We are looking for, is there an aneurysm in the carotid artery? Is there anything in the belly, any artery which affected especially the renal artery? These are the coinciding factors because, again, we think this is somewhat related why someone will have the spontaneous dissection while the others don't. Do you have some sort of genetic abnormality which affects it everywhere else in the body? And we talk about future pregnancies, and that's a serious conversation to have usually with the women. And again, there is a fun stuff there. Exercise is very important. The one lady asking, what's your favorite exercise? Sudoku. I don't think so. It's like getting on the treadmill is a better thing to do. So what about heart failure? How is women different? 5 million in the United States, 50% women, of course, older age, mainly with multiple risk factors. The heart failure with reduced ejection fraction, we call it HFrEF. That's one of and the other one is the heart failure with preserved ejection fraction, that's HFpEF. And one of the HFpEF is the normal ejection fraction, but heart failure symptoms. The death and the hospitalization is very similar to the women who have decreased ejection fraction. So what is the normal ejection fraction? The normal ejection fraction is 55 to 65%, not 100%, because the blood needs to be inside of that chamber. So it's not able to 100% contracting because then you have no way or you can't push it out to the whole body. So 55, 65% the normal. What is the HFrEF? The HFrEF is when it's less than 40%. And then the HFpEF, when they have actually 55, 60% normal, but they have severe diastolic dysfunction, meaning that the muscle is not able to relax. And that increases the pressures and increases the pressure also inside of the lungs. They have more shortness of breath. And women are more prone for this HFpEF than men are. And it's called non-ischemic cardiomyopathy also because there is no previous heart attack or anything to predict that these women will have that. On the other hand, high blood pressure, smaller cavity size, and obesity has some role, as we know of. And we have very few women, unfortunately, in the large trials, which would help us to really decide better about the treatments. These patients with heart failure with the reduced ejection fraction, the diuretics is the mainstay of therapy. These water pills are also important for the HFrEF too. And we like to address that to make sure that they don't have underlying coronary artery disease. And the treatment of high blood pressure has a major role in this. Well-controlled blood pressure, which is nowadays between 120, 140 systolic, and the diastolic pressure certainly less than 90 or 80. And also, we know everybody, we ask and we actually recommend to have a workup for sleep apnea also, because we know that sleep apnea can worsen any of these conditions. So then the next is the chest pain. You probably hear it every time when we have the Go Red for Women, or February is the Women's Heart Month. we usually talk about the chest pain. And the chest pain is, I always tell to the patient, is not necessarily a pain. It's a discomfort, it's a heavy feeling, it's something different. And women sometimes have more than one symptoms. They can have radiation to the back. They can have it, nausea, vomiting. They can have just not feeling well, fatigue. And we recommend that, when you are not feeling well, you should be checked out. And we teach also now the emergency room doctors too, not to send the patients away when they come with sort of not very typical symptoms for heart attack or heart disease. So we like to have this reminder for the women that can feel like a tightness or can feel like squeezing or burning and can be actually not just in the front of the chest but back. The radiation can be to the arm, to the jaw. But we also say that, just because we say to women that your symptoms can be different, but it doesn't mean you cannot have the typical symptoms how heart attack presents, chest heaviness going to your arm, shortness of breath going to your jaw. That's also, can be women. So women not always have to have these not so typical presentations. So don't delay, it's one of the main things what I'd like everybody to remember here, that do not delay to go to the emergency room. A quick visit can give you answers right away. A quick EKG, we can get an answer within 5 minutes when you arrive to the emergency room. Most of the emergency room take chest pains very seriously. You are not waiting usually 6 to 8 hours. We also like not to be driving yourself to the emergency room. If possible, we would like to have an ambulance to take you. It's sometimes not so easy in rural healthcare, but we certainly don't want the patient themselves driving. That's absolute no-no. Now, we talk about the stable ischemic heart disease. The stable ischemic heart disease is when someone had already heart attack, or we know that they have coronary disease, they have the plaques, the atherosclerosis, the buildup, and then we know also that we see more women with this stable ischemic heart disease, and they are usually older. They have what we call like the microvascular disease. The ejection fraction is preserved, so it's still normal, but more common in younger women, the microvascular disease. 50% of women who had angiogram has no obstructive disease. I wonder that some of them actually had a SCOD in the past, or they have this what we call small vessel disease. The symptoms are not the typical one when you have a typical symptom for the women. We go in and do an angiogram. We usually find the typical findings, occluded big artery, we put a stent in there, and we are not treating it any differently than any man or anybody who comes in with these kind of symptoms and findings. There is really no difference there. There were some study in the past, like 30 years ago or something. It was published in the New England Journal of Medicine that women did not receive enough stents and were not treated the way how men were treated. I can guarantee you that in 2025, it is not the case. Any woman comes in with the same symptoms as a man would come in with a heart attack, they would be treated exactly like that. Endothelial dysfunction and plaque erosion is more common, and also this distal embolization, meaning clot going far away from the vessel, is somewhat more common in women. Now, there was one trial, I'm not going to through 15 trials here, but one trial was very interesting, and that was the COURAGE trial, which compared medical therapy with the stents and with patients who had stable symptoms. So these were not the patients who came in with a heart attack. And they found no major difference in the outcome, that the patient got a stent or the patient had medical therapy. So we now try to treat as much as possible with medications. And if the medication fails, meaning the patient continues to have symptoms, We are not waiting for a heart attack. I'm talking about recurrent chest pains affecting the life. The chest pains, if we cannot treat it with medication, the stents actually is a good option. But the stents should be placed on people to relieve the pain so they can live their life the way how they would like to live their life. But the COURAGE trial enrolled very few women. Despite that, the mortality of women who received stents was higher than men. It's most likely because they were older stents, they were smaller vessels, so I think that's also changing with the times. And the procedural complications were higher, but recently, that time we used to do angiograms from the groin going to the femoral artery. Nowadays, majority of the patients, when they come to our cath lab or catheterization or angiography, we are using the radial artery, which is the arm, and this is much likely have any kind of bleeding complications or bruises or anything what we used to have when we went from the groin. Again, a little bit harder for the women to do that because, again, women are smaller. When I was doing angiograms, sometimes they use really small catheters to be able to put into the smaller arteries. So it's not 100% successful, but 80% of the time is. So then here is the heart attack. This is, again, an older data. As I said, we go through history here, too. So 2012, the STEMI, or the heart attack data, showed that women less likely receive guideline-recommended therapy, such as medications, more complications after PCI, or the dilation, balloon dilation, is mainly because of the growing complications. There is a sex-specific difference in high-sensitivity troponins. Men has twice the upper limit of normal than women. Now we are decreased the numbers what we look at when the patient comes in, and you get a different number for the women than the men, and we think it's normal or abnormal. And decreasing that diagnostic threshold actually benefited for women. Rather than saying that nothing wrong with you, we took it more seriously and did more testing for that. And what also we know that we were more likely to have what we call non-STEMI, when they come in and they don't have these typical EKG findings, but they can have something on the EKG, but not something what makes them run into the cath lab right away. So this is something what we know now. So this is an interesting, one of my favorite. This is a heart. And this is what you don't see, what we don't see when we do an angiogram. This is the microvascular disease. And we know that this is called actually the female pattern. Women are more likely to have that than others. And I think I have to finish up quickly. And this is the sex differences out of hospital cardiac arrest, which is also interesting. And the implantable defibrillator, which is different usage for women than for men. Women less likely to get an ICD, and that's also because they have actually showed less survival benefit than men do. And there was the breast cancer. We know that radiation can affect the coronary arteries, especially before they did the protection and cover-up, so that's also something to think about for us. And then here is the stress, which is history of anxiety, history of depression, and that causes another disease, which is called the Takotsubo, stress-induced cardiomyopathy, and this is how it looks like. The heart changes the movement, and it becomes like dilated at the apex, and we know that's all from the stress. Treatment is the same as the heart attack, and the EF, the ejection fraction, usually normalizes. And then here is the last one. You can read it on your own, who should be taking aspirin. And that's actually an important message here, that if generally don't take aspirin a day, if you are 60 years and older, and you don't have known heart disease previous stent placement. And this slide is not just because it's the end of the talk, but also highly recommended to have yoga. We know the benefits on the heart, And we recommend everybody to try at least a couple sessions of the yoga, and they would benefit their heart. Sorry that I went over. Any questions?
Thank you, Dr. Farkas. Thank you for being a part of the Rock from the Heart community and for joining us today. Your presence and engagement make a huge difference in raising awareness and building a stronger support network for those affected by aortic and heart valve disease. Thank you so much for attending today.